Dr. LaCourse is an associate professor in the division of ID, also global health, and also epidemiology at the University of Washington. She conducts research focused on TB prevention and diagnosis in HIV-affected populations, including children and pregnant women. She is the lead author of the LTBI section of the National HIV Curriculum and the up-to-date chapter on TB infection and pregnancy, which is probably one of the more widely read things that she's written. And importantly, she's the lead for the Pregnancy Review Group for the US-based opportunistic guidelines. So I think in summary, we can say that Dr. LaCourse is a national expert on TB and probably international expert on TB and pregnancy. We're very lucky to have her as part of our panel and very lucky to have her giving this talk. Take it away, Sylvia.
Well, thanks for the opportunity to talk today. I wanted to make sure you can see my slides and hear me clearly. Great.
Yes, we can.
Here's my conflicts of interest and disclosure statement. Great. The objectives, I try to underline the important things. So today we're going to talk about the treatment of latent TB infection during pregnancy. We'll talk about treatment recommendations for drug-sensitive TB during pregnancy. I think drug-resistant TB, MDR, et cetera, in pregnancy is its own topic. Spoiler alert, not a lot of data, but some promising data that people are doing okay with newer regimens. But we won't talk about that today. We'll identify some gaps in our understanding of TB in pregnancy and potential next steps to try to answer those science gaps and to improve our care of pregnant people with TB. And lastly, I have a couple of slides on resources that if you're interested in delving more into this topic. I love this slide, this picture, and this study. So this is, for those of you who are thinking, so why do we care about TB and pregnancy in children? It's been around for a very, very long time. And in fact, the oldest known case of TB confirmed by DNA was actually in a pregnant person and their infant, which they found during an excavation. And so there were bony changes, and unfortunately in both people that were consistent with TB. This was probably not congenital TB. This was probably TB that the infant was exposed to during early life and then had TB. So this is actually a real issue, right? And so I think I just like sharing this slide. We're going to start with the question. And I believe we have a poll. So which of the following is false? So which of these is not true? And you get to pick one. So A, regarding TB in pregnant people. So A, INH should be given for 6 or 9 months, 6H or 9H. It's recommended as first-line treatment for latent TB infection in pregnant people with HIV. Number 2, if pyrazinamide is not included for pregnant people, treatment for drug-susceptible TB with isoniazid, rifampin, and ethambutol is extended from 6 to 9 months. C, shorter course rifapentine-based regimens, including 3-HP or 1-HP, are recommended for pregnant people because of their improved tolerability and adherence. D, there's a theme here for shorter course regimens. Shorter course rifapentine, moxifloxacin-containing regimens for drug-susceptible TB, often known as 4-HPMZ, are not currently recommended during pregnancy. Or last one, E, chest x-rays are considered safe in pregnancy and should not be avoided even in the first trimester for the workup of latent TB infection and TB. So pick which one of these is false, which one of these is untrue. It looks like we have a poll up.
Okay, we are at 30% participation and it's still climbing.
Give people a few more seconds. Great, let's call it. Shall we take a look at the poll? Excellent. So what I really like about audience participation questions, I don't need to do this lecture, right? If everybody has the same answer. And so this is fantastic that there's quite a spread here. And so in my opinion, C is not correct. So the first one, isoniazid, is recommended as first line for latent TB infection in pregnant people with HIV, is the important caveat. Number 2, if we aren't going to use pyrazinamide as part of our therapy for pregnant people for drug-susceptible TB, we have to extend our treatment out for 9 months. C is wrong. Currently, 3-HP, we'll see about this later on in the talk, 3-HP and 1-HP aren't currently recommended. So that is wrong. So it's the right answer. And D, the shorter course regimens are not currently recommended in pregnancy due to a lack of data, but hopefully we'll be changing that. E, chest x-rays are safe in pregnancy and should not be avoided even in the first trimester for workup of latent TB and TB. So hopefully I can show you at least 2 articles that might make you feel more comfortable about that. So again, C is false, and so it's the right answer for this question. Thanks. So when we think about the global burden of TB, many of us know these numbers, the 10 million new diagnoses that occur each year, about 33% occur amongst women, the majority of which occur during ages that are considered of potential pregnancy potential. But what we don't know is how many cases of TB during a pregnancy occur. And so from modeling estimates, looking at the rates of pregnancy and the rates of TB amongst women of ages considered to be of childbearing potential, we think it's about 200,000 a year, but it's likely higher. And I'll show you some data that might support that. And it's likely underreported. So when we think about reporting, the nice thing is in the US, since 2020, if you've noticed on your case report forms, I was part of these conversations. It was great. They were asking sort of expert opinions, what should be included. And so as part of the case report forms back in 2020, pregnancy was added. And so now you'll notice on those forms, it says, was patient pregnant at the time of diagnostic evaluation? So yes, no, or unknown. That's fantastic. So I think that that's a gap, and it's great that that data is now being collected. But optimally, and hopefully I can make this argument to you, we would also include gestational age at the time of diagnosis and the postpartum period, because sometimes TB is missed during pregnancy and people are diagnosed in the early postpartum period. And it would be nice to know about the infant outcome. And I'm just curious, feel free to put this in the chat. I'm curious how people are coding this on their report form when it's actually really a misdiagnosis that happened during pregnancy and the diagnosis is made in the postpartum period. Are you clicking yes for pregnancy here or not? Because how we collect the data, really affects what answers we get. And so I'm curious, I'd love to know in the chat how you all are dealing with that with an early postpartum diagnosis. Are you clicking pregnancy on your case report form? The reason I'm talking about this postpartum period is when we look at the risk, there's been a couple of large-scale epidemiologic studies that looked at the risk of pregnancy. And these were actually in low burden settings, which I think is helpful because there's not a lot of ongoing exposure that can be confounding, right? And so when they looked in both a UK cohort and also in a Swedish cohort where people are followed through life, and so you have data on them pre-pregnancy, during pregnancy, and post-pregnancy, they found that the risk of pregnancy was about almost 2 times higher in that early postpartum period versus non-pregnancy times. And so you can see it's going up a little bit during pregnancy and then in that early postpartum period and then coming down again. And why do we care about TB during pregnancy? Well, it results in poor both maternal and fetal outcomes, including miscarriage, preeclampsia, mortality, etc. And a number of adverse fetal outcomes you can see there. This is often compounded by HIV, even in the setting of widespread medications to treat HIV. And so, many of us live and work in Washington State or in the surroundings, but this is happening here in the US too, right? And so this is just one example. There's many case reports of undiagnosed TB during pregnancy. And in this case, this MMWR, it unfortunately resulted in a neonatal death. So it's not common, but it does happen, and it happens here in the US, even in the setting of being in a well-resourced setting and with HIV not this part of the issue. So there's a number of absolutely normal immunologic and physiologic changes in pregnancy that may potentially increase the incidence as well as severity of some infections. Additionally, there's physiologic changes that may affect the dosing or frequency of the timing that medications need to be given, and potentially the severity of adverse effects with medications. Lastly, the signs and symptoms of some infections may be masked by common symptoms of pregnancy. This may have implications for, are there immunologic changes that are totally normal during pregnancy that could potentially increase the risk of progression to TB? And then obviously this has implications for both TB prevention and treatment. And I think this is compounded and complicated by the fact that there's frequent lack of data regarding drugs in pregnancy in general, TB specifically. Pregnant persons are routinely excluded from clinical trials. And then a lot of the time, we look at animal data, but animal studies may not correlate with human findings. And it also depends on what animal model you're using. So this is obviously, this is an issue. In terms of TB diagnostics in pregnancy, in general, they're the same for a pregnant person or a non-pregnant person. In the next slide, we'll talk a little bit about imaging. A few additional diagnostics that people are thinking about with pregnancy is sometimes when we're thinking about a diagnosis that's happening in near the delivery, that there'll be placental sampling when we're worried about congenital TB, et cetera. And then a research question that's I think will be really interesting that folks are looking at now is there a role for, and again, this is for research, is there a role for cervical swabs, et cetera, to evaluate for GUTB? I want to talk about imaging because there's often, I think it's really important that we think about what the risks and benefits of any screening test, any diagnostic test, and any intervention that's happening during pregnancy. But let's look to the experts. So what do OBGYNs think about imaging in pregnancy? And you can see there that the ACOG, the committee opinion says, with few exceptions, radiation exposure through radiography, including CT scan or nuclear medicine imaging, is at a dose much lower than an exposure that's been associated with fetal harm. On the bottom, this is a really nice paper because it goes through multiple imaging modalities, and it really quantifies the number of grays, which is, we used to think of these as rads. So gray is a measurement of radiation. And you can see that the approximate fetal radiation exposure during most radiologic studies that use ionizing radiation is less than 0.05 grays. And then I think this is important for us to remember that the natural background of radiation dose to the fetus during pregnancy, this is without X-rays, this is just being a fetus in the world, is 1 milligrays. So I really, that second article, I think it's a really interesting read, and it has really good teaching points when we're thinking about imaging and pregnancy. And again, this shouldn't just be done without thought, but we should really be thinking about risks and benefits, specifically the risk of not evaluating conditions that we really need to use radiographs to provide us information. Screening for latent TB infection in pregnancy is the same for people who aren't pregnant, so I won't spend a lot of time on that. Pregnancy itself isn't an indication for screening, although antenatal care may provide opportunity to do so. And as we were hearing about the patient that Masa was talking about, I was wondering, was this person routinely being screened because they were in antenatal care? Maybe that was the indication. I'm not sure. I'm curious, maybe people can put it in their chat, in the setting that you work in, are pregnant people sort of being routinely screened for latent TB infection in your setting, not because of a recent exposure, et cetera, but because maybe it's just happening routinely. So I'm curious to, because there's some practice variation. So again, when you look at the guidelines, either a TST or an interferon gamma release assay, either one of these are reasonable tests to do to use to evaluate for latent TB infection. And that's the same for pregnant people. From a research perspective, it does appear that pregnancy actually may affect how these diagnostics work with the relative immunosuppression that's happening specifically in the later stages of pregnancy. We looked at multiple cohorts of both people with HIV and without HIV who were pregnant in both India and Kenya. We found that when we did paired tuberculin skin testing and interferon gamma release assays, you can see the TST is in green and interferon gamma release assays are in blue. You can see that amongst pregnant people, they were more likely to be IGRA positive than TST positive. And this is kind of a flip when we think about people living in high burden settings having potentially, who are getting BCG, having the prevalence being higher in TST than interferon gamma release assay. But additionally, interferon gamma release assays also appeared to be affected by pregnancy. And so this cohort, you'll see that that first pink bar is 100%. So everybody in this cohort, including if they had HIV or not, these are all pregnant people who were QFT positive during earlier stages of pregnancy and were repeatedly testing. You can see that at delivery, both the proportion of people who were positive at that time goes down. These are the same, this is the same cohort followed longitudinally. And it's really the MTB antigen responses were going down. So also the number of people that were positive. So it seems that pregnancy appears to differentially affect both tuberculin skin testing results, as well as interferon gamma release assays. Now, again, the guidelines, you know, when you're routinely working somebody up for LTBI, you should use the diagnostic that you have available to you. But I just think that this is data to show that there's something going on with pregnancy that may affect these testing modalities. I actually wasn't going to bring this slide up, but I think it's interesting because we've talked a little bit a couple weeks ago. Bijan talked about subclinical TB disease, etc. And so, you know, this is a topic that people are really interested in. And it appears, and again, subclinical TB disease would be somebody who doesn't have symptoms, but if you took their sputum, we could actually, their culture or their expert would be positive. And so there's been a couple of studies. We've looked at the symptom screen in the WHO symptom screen in multiple populations and found that it had reduced sensitivity, specifically amongst pregnant people with HIV. And then there was a systematic review where they looked at multiple studies, a lot of heterogeneity in the studies, you know, some were cohort studies, et cetera. And they found that symptom screening actually missed a lot of pregnant people who actually had subclinical TB disease. And so really more than half, again, a lot of heterogeneity, but more than half of these pregnant people in this systematic review, I had no reported symptoms, but had bacterial confirmed TB. I have two slides that focus a little bit more on why is this happening in pregnancy. And so why is this happening in pregnancy? We had the opportunity it's very rare to have samples from people before pregnancy, during pregnancy, and after pregnancy, but we had opportunity to look at that to see if were immunologic changes that were TB specific that might account for both why people might not be having symptoms or having subclinical disease during TB during later stages of pregnancy. And we found that the TB-specific CD4 T cell responses and also T effector memory cells seem to diminish in that third trimester. And then additionally, we found that these non-specific T cell activation markers were increased in the third trimester. So we could hypothesize that maybe these changes that are occurring really at the nadir and late pregnancy, for somebody who already has latent TB infection, could it be associated with loss of containment and maybe postpartum TB disease? But again, this is, we're just hypothesizing this. Lastly, the last piece of sort of immunologic data is we've looked at gene sets there's a number of different gene sets that have been published in non-pregnant populations that appear to predict who's going to go on to develop active TB disease. And so Jyoti Mathod and her group have looked at this in both pregnancy and postpartum. And I'll just say that was interesting because they found two different pathways that seem to be associated with people who developed TB during pregnancy, as well as those who developed TB during the postpartum period. And the important thing is neither involve the interferon gamma pathways, which is interesting. And so I'll just leave this there, but just it's food for thought, thinking about what is different going on. What are the differences in pregnancy in the early postpartum period that might affect both how people are presenting as well as some of our diagnostics. Okay, now let's get back to the bread and butter of our clinical care. So what about the timing of TB prevention in pregnant people? And so Masa had that nice question that came up. Would you do X-ray? And then if it was positive or if it was negative, but you wanted to offer, would you offer LTBI treatment now or would you wait? And so this is the recommendation. So in low burden settings, people are at higher risk. And I saw questions in the chat. People are at higher risk. So if they've had a recent conversion in either their TST or interferon gamma release assay or a recent contact, the idea is to treat now for latent TB infection, even in the first trimester. If people are at lower risk, you can consider waiting until after delivery or 2 to 3 months postpartum to think about potentially avoiding the risk of typically isoniazid associated hepatotoxicity. In higher burden settings, the recommendation is a little bit different, and it really focuses on pregnant people with HIV, and if they have either an unknown or a positive latent TB infection test, the idea is to treat now, regardless of recent exposure or test conversion. But I think the issue is we have to weigh these things and have conversations with people and talk about, is there opportunity while people are engaged in the healthcare system? We have to think about comorbidities, risk of reactivation, risk of progression to TB disease, and the risk of side effects. And I think the problem is when we think about higher risk and recent conversion, they usually don't have that prior testing, right? Somebody's coming to care now, they're in antenatal care, we're getting a test now. We don't know what the if this is a recent conversion or not. So I think that that's the difficulty. I want to briefly touch on the hepatotoxicity and INH in pregnancy. So imaging sometimes gives people pause, and the use of isoniazid during pregnancy gives people pause. So part of this comes from, there's been data regarding hepatotoxicity during pregnancy. And so part of this comes from in the late 1980s, so in 1989, there was, this was a published report, and where these were people who were pregnant people who initiated INH during pregnancy, excuse me, so they initiated INH during pregnancy. In this cohort, people were given a 3-month INH supply and then seen every 3 months for a 12-month duration, and routine LFTs were not performed unless they were symptomatic. Now, of these almost 4,000 people, 5 pregnant people developed hepatitis and 2 died postpartum. And again, this is a medication to help prevent a disease, but there were 2 deaths. And so when they looked at the risk, they thought that there was about a 2-fold increase in INH hepatitis, but it wasn't significantly, it wasn't statistically significant compared to when they looked at the same numbers in non-pregnant people versus pregnant people. Additionally, there was a case series of 20 INH-associated deaths in California. And of those 20 deaths, 4 had an initiated INH in pregnancy. And so these are real important concerns that were about hepatotoxicity and isoniazid in pregnancy. But it's important for us to understand what the details were of these cohorts and this case series. Interestingly enough, in subsequent large case control and cohort studies of pregnant and postpartum people getting isoniazid in high burden settings as part of a routine program, it didn't appear to be associated with hepatotoxicity or adverse pregnancy outcomes. But we'll see a little bit about some data of a trial that evaluated isoniazid in pregnancy. So I would say the data is a little bit mixed. When we're thinking about, I've been focusing on isoniazid, but what about these shorter course regimens for TB prevention? And so as we know, 3-HP, 4R, and 1-HP are all associated with increased completion rates and decreased discontinuation due to side effects. So that's fantastic. So shorter does appear to be better, at least in some populations. But the issue is pregnant and postpartum people were roundly excluded from all of these studies. So what are our current TB prevention recommendations for pregnant people? And so in the US, and so I'm basing this on the guidelines that we use in the US, the recommendations are that either 4 months of rifampin, 6 or 9 months of isoniazid, or 3 months of daily isoniazid and rifampin can be used during pregnancy. I would say in practice, many experts, many clinicians really prefer using rifampin during pregnancy if the decision is made to treat during pregnancy and early postpartum to really avoid the hepatotoxicity risk. Although when we're thinking in certain populations, specifically people living with HIV, we have to think about drug-drug interactions. But isoniazid is still the preferred treatment for pregnant people with HIV. Additionally, with the 3 months of isoniazid and rifampin given daily, we also, because of the rifampin, we have to think about drug-drug interactions with some ART. And importantly, as with other populations, we should be administering paroxetine with any isoniazid-containing regimens. So in terms of monitoring, specifically in this population of pregnant people, it's important to do baseline LFTs. And although it's not mentioned in our national guidelines, I love it that the Washington State guidelines do specifically call out that in pregnant people that it's prudent to get monthly evaluations, including LFTs during latent TB infection treatment. Unfortunately, so 3-HP, which we use routinely in other populations, is not currently recommended in pregnant people due to gaps in data, although I'll show you some pregnancy safety data. And then the 1-HP regimen, which is considered an alternative regimen, is not currently recommended because of no data, but we'll talk about a study that I co-lead with colleagues that are evaluating that called the Dolphin Mom study. So we do have some data that's looked at TB, looked at isoniazid in pregnancy. So this is a clinical trial called the TB Apprise study that looked at women who were pregnant, were randomized to receive 6 months of isoniazid either during pregnancy or postpartum. And the outcomes included composite adverse outcomes during pregnancy, as well as hepatotoxicity. And what's interesting is this study showed that there was this increase in this composite adverse outcome associated with isoniazid during pregnancy versus postpartum. And when you looked out from what that composite outcome, it was really driven mostly by low birth weight and preterm delivery. Additionally, we've been talking about hepatotoxicity, and I think one of the strengths of this study is there wasn't a difference in hepatotoxicity getting either isoniazid during pregnancy or postpartum, but you can see that the postpartum hepatotoxicity rates in both arms were higher than expected, but similar. And so really, when you're thinking about this, this probably shows us often what the natural history of LFTs are happening. And this is, if in case the print's too small to see, that peak in LFTs is really happening around the 12-week period. So this really kind of coincides with what we see clinically and what we're concerned about this risk of postpartum hepatotoxicity. Now, even with these trial results, the WHO recommended that we shouldn't defer isoniazid to postpartum. We shouldn't defer isoniazid to the postpartum period for people with HIV who are pregnant, because it would derive them of significant protection when they were highly vulnerable to TB. So I think this just shows the tension between recommendations that are happening in high burden settings and are happening in other settings, such as the US. What about 3-HP? 3-HP has actually been evaluated in pregnant people. And a small cohort of 50 pregnant people, including both those who had HIV and who didn't have HIV, was found to be very well tolerated in maternal infant pairs. Women with HIV did have increased clearance of rifapentine during pregnancy, so they were metabolizing it quicker. However, no dose adjustment of rifapentine was required. But this wasn't enough data to move the needle to change our current recommendations. Gaps. This study enrolled women who were with HIV who were on older ART and a efavirenz-based regimen, which is not what we use routinely now, and it wasn't powered for safety. This was really a PK study. What about our shorter course regimens for TB treatment, including even though, and that we even recommend for people living with HIV? Well, we've talked about this in a number of sessions here about the new 4-month HPMZ regimen, and that the CDC and WHO recommend that 4 months of HPMZ as a potential option for adults and adolescents for drug-sensitive pulmonary TB, including non-pregnant people with HIV with CD4 counts above 100 who are on a efavirenz-based ART, because that's who was allowed to enroll in the study. But again, pregnant and postpartum people were excluded. So you'll see this pattern of pregnant and postpartum people are excluded from these trials that are showing us shorter may be better, but we can't yet make that recommendation because we still have gaps in data. So when we're looking at TB treatment recommendations for pregnant people, in general, the recommendation for drug-sensitive TB is really there's two options. And so there's the 6-month regimen of HRZE, although some guidelines recommend avoiding PZA. And if so, again, that treatment of 6 months now gets extended out to 9 months. HPMZ, as you can see there in yellow, is not currently recommended due to no data. However, a trial is in development to look at HPMZ in pregnant people. In terms of our standard, we've talked about that there's no data, there are very little data in short course regimens for either latent TB infection treatment or drug-sensitive pulmonary TB. But what about our standard of care, 6 months of HRZA in pregnancy? And so we actually have very little data of the regimens we use routinely all the time. And there's an Impact 2026 study that actually looked at what were the concentrations in pregnancy versus postpartum. And they found that isoniazid and ethambutol concentrations were lower in pregnancy versus postpartum. Rifampin and PZA were similar in pregnancy and postpartum. You can see rifampin, isoniazid, and PZA met those therapeutic targets. But interestingly, ethambutol did not meet the therapeutic targets. And so these are at our recommended dosing regimens at the recommended doses for drug-sensitive TB. But I think it just goes to show these are drugs that we routinely recommend in pregnancy. And there's really sort of one study that really has looked at the PK of these drugs. We talked about gaps, about the short course TB, latent TB infection treatment regimens. Hopefully, we'll have more data on this. And so currently there's a trial ongoing where pregnant people with HIV who on a dolutegravir-based regimen are randomized to receive either 3 HP or 1 HP, and then they're followed out. And it's a PK and safety study because we assume that efficacy will be the same. And they're followed out, and we are looking at both PK as well as pregnancy and infant outcomes. So stay tuned. Probably we'll have the results in the next year or so. Other studies that I'm aware of is there's a breech TB study that's going to be assessing that will allow enrollment of pregnant people that will assess bedaquiline as TB prevention, including both adults, children, and pregnant people. And this would be a regimen for both TB prevention for both drug-sensitive and drug-resistant TB. So it will be very interesting to see when that study starts. And then a little on the more depressing note was that WHO had recently come out, based on data from a couple of landmark trials about tuberculosis preventive treatment in the setting of MDR, and making a recommendation about using fluoroquinolones, but pregnant people are not included in these recommendations. They're not even mentioned, so neither a thumbs up or a thumbs down recommendation. So in my mind, that's a big gap. What about breastfeeding during latent TB infection treatment or drug-sensitive TB treatment? So breastfeeding is not contraindicated during latent TB infection treatment. First-line meds typically are found in small concentrations in breast milk, thought to be non-toxic to the infant, but importantly also not effective treatment for the infant. So just as that case that we heard earlier, infants need to be evaluated and then receive their own window prophylaxis. And this is a nice, and if you ever have questions, I really recommend going to the LactMed, and you can search drugs to see what drugs are thought to pass through breast milk. We've been talking a lot about TB, latent TB treatment and prevention during pregnancy, but I think it's also important for us to remember that about TB and people who wish to avoid becoming pregnant. And so 20% of global TB occurs amongst people who have the potential to become pregnant. And so I always like to remind us that for people who are wishing to avoid pregnancy, we have to just remind ourselves what the drug-drug interactions are between rifamycins, and that they can decrease the effectiveness of some contraception, specifically the contraception pills, the patch and the ring, but okay with IUD. And you can see here also, we have to think about drug-drug interactions when we're thinking about emergency contraception. Lastly, when we're thinking about people who wish to avoid pregnancy or wish to become pregnant, that for those undergoing assisted reproductive treatment, female genital TB is likely greater contribution to infertility than previously thought. And as we've heard about this past year, there's been a growing number of IVF-related congenital TB case reports. I just have two more slides here. And so moving forward, there's been this move. There was a meeting that was sponsored by the WHO, the Impact Network, and this other large consortium called Smart for TB that's running a number of clinical trials that really is trying to come together and build a primer on TB and pregnancy, really sort of laying the groundwork for consensus so that people who are considering designing trials, et cetera, or designing surveillance systems, how to effectively include, effectively include and not exclude pregnant people from these studies. It's nice to see that the most recent WHO roadmap about ending TB amongst children and adolescents in 2023 really talks about for us to effectively address TB in infants and young children. We cannot, this issue cannot be separated from effectively addressing maternal TB. This is a very nice article, and even, I suggest reading it, even though it really sort of focuses on the pathway for TB and care in a high burden setting. But I really love how it talks about sort of the barriers that a pregnant person might meet along the way of getting diagnosed, getting effective therapy, et cetera. And then it talks about best practices to help reduce these barriers. And I think it's helpful for any of us to read, no matter what setting you work in. And so I'll end there, and I just thank you, and we can take any questions or discussion, but I really appreciate the opportunity to discuss this topic today.